Welcome to AETCM, the Emergency Medicine Channel. A 56-year-old female presented to ER with complaints of abdominal pain and fever since 3 days. On initial 10-second assessment, patient was conscious-oriented, airway was patent, no pooling of secretions, breathing, respiratory rate was 18 per minute, saturation 100% on room air entry bilateral equal. Coming to circulation, BP was 130/90 millimeters of mercury, pulse rate 103 per minute, all peripheral pulsations equally felt. Coming to disability, GCS was 15/15, pupils equal and reacting to light. Exposure, temperature 100 degree Fahrenheit, GRBS was 100 milligram per deciliter. Coming to history, a 56-year-old female with complaints of abdominal pain and fever since 3 days. Pain was mainly periumbilical and was no association with foot. She also had complaints of loose stools and vomiting, no history of dysuria or decreased urine output. Patient had similar complaints 4 years back and was diagnosed with acute appendicitis with concealed perforation and was managed conservatively. On examination, patient was conscious oriented, no pallor ectocyanosis clubbing lymphadenopathy. Coming to local examination, per abdomen, there are no fistula, any scar marks or nothing was there, no abdominal distension, abdomen was soft, there was right iliac fossa tenderness and rebound tenderness was positive, no organomegaly, no abdominal distension, bowel sounds were normal. Other systems were within normal limit. So we had taken a point.
Rebound tenderness was there?
Yeah, rebound tenderness was there. Coming to CBC-CRP point of care, total counts were 12,000 with a neutrophilic 71.9, CRP was 68.32. So we kept a differential diagnosis of appendicitis because earlier also she had similar episode, and we did a USG abdomen. USG abdomen showing inflammatory changes in right iliac fossa with suspicion of acute appendicitis with collection, suggested CT scan, and grade 1 fatty liver. So we had taken a CT abdomen with showing an appendicular abscess 2 into 2 centimeters with inflamed appendiceal tip, no appendicolith, and extensive inflammatory changes extending to cecum fossa.
So what was done to that?
We were started on injection, cephalosporin sulbactam, and she was managed conservatively this time also.
Conservatively, without drainage or pigtail drainage, anything?
No, without pigtail.
Just with IV antibiotics she was managed and she was discharged. What is the plan for her after that? They are planning for an internal appendectomy or they are not planning for it?
Planning anything.
Okay. So basically we have a 56-year-old lady who has come with an acute abdomen. So as an acute abdomen, this is a straightforward, we had a background history of acute appendicitis with perforation. Now again she had come with a similar episode, so it's an easy go for us. So that's easier, but loose stools and vomiting again she had. So what could be the differential diagnosis that you need to consider for a 56-year-old coming with an acute abdomen to the ER?
Acute gastroenteritis.
Acute gastroenteritis. Okay, why acute gastroenteritis? Usually isolated tenderness you won't be able to get. Maybe you have generalized tenderness you will be able to see.
Then diverticulitis.
Diverticulitis, that is again in the left iliac fossa, more on the, not in the right iliac fossa. Then
any ovarian pathologies?
Ovarian pathologies, okay. Ovarian pathology, 56-year-old. Torsion, again loose stools is not fitting to an ovarian pathology. Then
ureteric calculi.
Ureteric calculi, okay. Ureteric calculi, but tenderness again it's against an ureteric calculi. Then
any adenomyosis.
Adenomyosis, okay. 56-year-old, why she should have an adenomyosis now when she never had this before? Most importantly, elderly age group, we have to think in terms of a malignancy. That's one thing. Maybe it's a first time presentation, can be something similar to this. Even appendicitis, we think of an appendicitis, it can be an underlying malignancy for this age group. But she had a previous history, maybe at the age of 52 and all, but when they are having some 56-year-old, and we have to consider one differential diagnosis as malignancy as the most important thing. And UTI unlikely, but she never had. But usually dysuria, sometimes they might not complain of. So UTI is another one of the commonest differential diagnosis. Again, loose stools, not very common, but you can have different sort of presentation. So basically what we'll have to come down on diverticulitis, colitis, whatever be it is, and an acute appendicitis as the closest differential diagnosis in this area, but left iliac fossa will be concentrating on diverticulitis. And another important thing as an ED physician is to differentiate whether there is any evidence of peritonitis is there or not. That is our concern. So if there is peritonitis, the treatment completely changes. If there is no peritonitis, the treatment differs. So clinically, how will we be able to differentiate between a patient who's coming with an acute abdomen, whether they're having peritonitis or non-peritonitis, from starting from inspection onwards?
Vital signs will be tachycardia. If there is perforation, there's a hypotension.
So they will be sick looking. You can just put it as sick looking. They will be more toxic. Simple appendicitis will not be this toxic. The peritonitis, they will be more toxic. Like as you said, tachycardia, hypotension, febrile, and mostly they will be diaphoretic. All those things will be there. Then
On inspection, the abdomen will be bored, like rigidity will be there. It's no
okay.
movements.
So they will be reserving the movements of the abdomen. Okay.
Then
on palpation,
it will be guarding, rigidity will
guarding
be there.
and rigidity. These are all classical signs, and anything else in the inspection that will be able to elicit. Not in a case like this, maybe an acute pancreatitis, or maybe you are having a lot of other features of peritonitis, maybe a hemorrhagic. All the signs, the classical Cullen sign and great sign. It is to do with peritonitis. It is not specific for pancreatitis only. You can have any other pathology also. You can have. Will you suspect a mesenteric ischemia in this patient?
Generalized abdominal pain.
Mesenteric ischemia. When will you suspect a mesenteric ischemia? So the classical red currant jelly stool and all you might not be able to get in the history. Okay. So the patient might come. She had a loose stool, sort of an episode, and she had some bloody diarrhea. And she's coming with an abdominal pain. So another closest differential, mesenteric ischemia, and also mesenteric ischemia, you can have arterial as well as venous. So that is the most common. Arterial, we'll commonly suspect when we suspect arterial.
Any malignancies?
Arterial, you have atrial fibrillation. Patient with atrial fibrillation now coming with acute abdominal pain on warfarin, all those things. Then again, mesenteric ischemia, where else you can have mesenteric ischemia? Common in our setup. Malignancy, okay. Then hypotension. See, you have to think in hypotension, we have an AKI, acute hepatitis. We have OTPT elevation AKI also. Similarly, when perfusion is affected to the intestine also, they can have these features. So mesenteric ischemia, one differential, and you can have arterial as well as venous also. So that is when you say mesenteric ischemia, we always think of arterial, but there is a venous perspective of mesenteric ischemia also. So our concern to see whether it is perforation with peritonitis or appendicitis with peritonitis. Peritonitis is our question mark. So do you say this patient has features of peritonitis?
Localized peritonitis, rebound tenderness was there.
Rebound tenderness was there. What is the reason behind rebound tenderness?
The mesentery.
When you are pressing and suddenly releasing, there is a stretch of the peritoneum. So we have two peritoneum, which will have a pain sensation. Visceral and we have parietal. Which one will have pain sensation? Parietal. Only parietal will have. So that when it is moving, the patient is complaining of pain. And initially it started off with the umbilicus, everything. It is fitting to our appendicitis only. So as in the emergency room, how will you diagnose? You have all the Alvarado score, all the scoring system, and all these things are there. You can apply all those things. You can get a sensitivity, specificity. But the most important among the Alvarado score is what is the most important factor that you need to consider in the Alvarado score. Only one thing. McBurney's point tenderness. So when you have a McBurney's point tenderness, that is the most important. When you take the whole Alvarado score, and you don't want to do for every patient doing the Alvarado score, just do the McBurney's point tenderness, and you just correlate with the patient, how the patient is progressing. The most important among the scoring system is the right iliac fossa or the McBurney's point tenderness. So if you want to do only one test, that I will say, one investigation, clinical examination, is McBurney's point tenderness. Can you let us know where exactly is the McBurney's point?
It's a line between umbilicus and anterior superior leg spine, medial 2/3 and lateral 1/3 junction.
That is the McBurney's point. What is that consideration of that area? What is the important landmark? What is junction. That? What is that? Why we are saying this McBurney's point is significant? That is where the
appendix.
Root of the appendix is there. So that is where the root of the appendix is there. Appendix have different ways. You can have retrocecal, cecal, lot of different area. But the root of appendix is always fixed. So that is the reason why we are saying for the McBurney's point of tenderness. So McBurney's point of tenderness, if you do Alvarado score, okay, that is okay. But you know the mandrels and all those things you can calculate. But in an ED, if you don't have time, just look at the right iliac fossa tenderness as single determinant factor. Then you decide, okay, he has having a right iliac fossa, you suspect an acute appendicitis. So how will you proceed further for a patient with acute abdominal pain coming to the ER? How you have proceeded for this patient?
Routine counts we can take.
Analgesics. First thing,
analgesics.
give her analgesics. So preferably you can give NSAIDs. No harm in giving NSAID. There is no contraindication. NSAIDs or paracetamol or milder opioids, weaker opioids you can give. And mostly you have to, when you are using opioids or any agents, you have to give antiemetics also. Then
hydrate the patient.
Okay.
Keep the patient NPO. Then send the blood routine investigations. See for total count elevation and elevated, and give an antibiotic prophylaxis.
Okay. So antibiotic prophylaxis. Okay.
Then we can initially do with the USG abdomen.
USG is the gold standard. Even if you say CT scan, USG is the gold standard for a diagnosis of acute appendicitis. That is more than enough for an clinically, and with an USG correlation will be more than enough. And previously, what was the thought that you have to surgically remove the appendix? But recently, what have come up only which have got complications, like a perforated appendix or significant peritonitis. We need to do a surgical exploration. And the sort of interval appendicectomy, what you used to see before and all, is not being practiced very frequently. And they are conservative. There are patients who come with 2 episodes of acute appendicitis, 3 episodes of appendicitis, but still they are managed conservatively. Unless and until you suspect any malignancy, you have, because if this lady is coming for the second time, a 56-year-old, personally, I'm not taking a surgically perspective. My consideration in the background, whether it's in any malignancy sort of a thing, is there under very rarely, but you need to have a consideration. So appendicular abscess, again, there are different ways by which you can tackle an appendicular abscess. If it's a very small collection, like as you said, 2 centimeter and all, we can manage maybe with IV antibiotics. Or else it's like a 10 centimeter or 15 centimeter collection. Previously we need to explore it, but now the intervention radiology has come up. So what they prefer is to do a small pigtail drainage and give antibiotics and drain the abscess, and you treat the appendicitis with IV antibiotics and reassess the patient with an ultrasound again, and how the patient is improving. So if the patient is improving and clinically she is stable enough, they are even discharging her without any surgery. So these are the changes that has happened. Maybe the last 10-15 years, dramatically the changes that happened when previously, when you look at the history of appendicectomy, appendicectomy was done open appendicectomies like in the years of like 98, 2000. From 2000 onwards, slowly in India, they started doing lap appendicectomy. So slowly lap appendicectomy started getting popular. By the time the last 5 years, the major changes happened is that you don't need to surgically treat all appendicitis. You can conservatively manage. So again, conservatively managing an appendicitis is very key. What are the preferred regimens for antibiotics? So preferred regimen of antibiotics is pretty simple and straightforward. We are having a possibility of a gram-negative infection. So gram-negative, why an appendicitis occur? What is the background pathophysiology of an appendicitis?
Any obstruction.
No, how can the obstruction happen?
Appendicolith can happen, or any lymphoid tissues, proliferation, any malignancies, and it causes obstruction and it causes inflammation, and the appendiceal artery may be blocked, and then it causes the appendicitis.
Okay, so there is some obstruction to the pathway, and it's a blindfolded structure. When there is an obstruction, you will definitely have inflammation to that. So appendicectomy was rendered before, but now they are treating it conservatively. And with what regimen of antibiotic you wanted to choose?
Either piperacillin tazobactam combinations, or second generation means higher
why not quinolones?
Levofloxacin.
You can start with a simple ciprofloxacin and levofloxacin, any of these quinolones, unless until there is a contraindication for what is the contraindication that you need?
Seizures.
Seizure threshold might come down. Already known seizure patient, elderly population, we might need to avoid quinolones. What is the other complication of levofloxacin or any of the? Tendinitis. So that is one of the QTC. Rarely, some group of drugs can cause QTC prolongation when you are giving an adjacent agents also. So, and another thing is an anti-tubercular agent. So, abdominal infection, okay. With the first episode, you can start for UTI and all. So, quinolones you can start off with, and always remember to give an anaerobic coverage also, because a lot of anaerobic organisms are there in the intestine. So, when there is a perforation sort of thing, you have to give an anaerobic coverage. Piperacillin tazobactam, straight away, I don't feel like, unless and until this patient is having a peritonitis, few days he was in the hospital and she is not recovering. Whenever I am suspecting a pseudomonas, anti-pseudomonal, definitely Piptas can be started, but otherwise a cephalosporin should be sufficient enough to start off with the treatment, and later upon you can decide upon the escalation of antibiotics depending upon the clinical factors. So usually 5 to 7 days of IV antibiotics, usually it will settle. Initially 48 to 72 hours you give IV and oral antibiotics if the patient is tolerating. After 24 hours you can stop NPO and start taking slowly oral feeds. Patient is tolerating, usually they are discharged. So that's the pattern what they are been practicing. And when you have to say, okay, this is have a CT. When you wanted to get a CT for an acute appendicitis?
If there is any suspicion of perforation.
Okay.
And then any
suspicion of perforation. Okay. Whenever you have another differential diagnosis in your mind, you need a CT. So that is the thing. You're not fitting into terms, somebody is doing an ultrasound and telling appendix is absolutely fine. So you are having some other suspicion. Why the patient is having an acute abdomen? Why, again, one thing that we missed is to discuss is the arterial conditions. A 56 or 60-year-old lady, you can have an aortic aneurysm. So that is another differential diagnosis they can. But loose stools, again, not very common. But always you have to have, as an ED physician, age, risk factors all together, we have to come up with our differential diagnosis. So that's the one thing. But CT is generally not required unless and until you are suspecting any local complication, as you said, perforation, or you wanted to see how much amount of peritonitis that happened. Maybe surgeon will get a clue before the surgery, and that only to be done if the patient is stable enough. If the patient is unstable, you can straight away take to the theatre. But the CT is only indicated when you have another diagnosis in your mind. You are not very sure it is an appendicitis. You are thinking in terms of something else as a differential diagnosis that is not fitting into your appendicitis. You don't have any much of a McBurney's point tenderness. You are not clinically correlating everything towards appendicitis. So then you have to have a CT scan. But routinely CT is not warranted for planning for your appendicitis. And usually they can be admitted, and that is a normal course of treatment what used to happen. Like this, maybe for this patient, maybe on later follow-up, they might be planning for an interval appendicectomy because she twice had a complicated appendicitis. It's not a simple appendicitis she had. She had initially with a contained perforation, then next she had an abscess formation. So maybe they would have been, definitely I feel they would have gone for an interval appendicectomy for this patient at least. Okay. So you have anything else to be added on?
The imaging findings in CCT suggestive of appendicitis is enlarged appendix diameter more than 6 millimeters with an occluded lumen, appendiceal wall thickening more than 2 mm, periappendiceal fat stranding and wall enhancement, and appendicolith, if you can say.
Okay. So she's discharged now?
Yeah,
she's discharged. Okay, fine. You have anything else to be added on? Fine. So what we discussed, an acute abdomen approach. Our clinical differential diagnosis you always keep in your mind. Acute abdomen can be tricky, can be medical, surgical or medical causes. So can we elaborate few medical causes for acute abdomen?
DK,
diabetic ketoacidosis, then acute myocardial infarction, inferior wall MI, then rarest of the rare, we will get lead poisoning, intermittent porphyria. So these are the medical causes always you need to keep in mind. And anything else that you have been toxin related? You said regarding lead toxicity. Okay, then the first sign of an envenomation, snake envenomation, will be to start off with an acute abdominal pain and vomiting, epigastric pain and discomfort. So somebody is coming with pain abdomen following in snake envenomation, you have to think there is a significant envenomation that is specifically to crate and viper. So when you see this and patient is complaining of abdominal pain and vomiting, you have to take it, whatever the parameters you are checking, it will be fitting to start off with your anti-snake venom. So that is the other medical cause that you need to keep in your mind. Fine. Thank you.